Here.
Oh,
And I'm
yes.
sorry for your loss too.
Well, thank you. Thank you. I think we've all, I mean, it seems sad, but I was so fortunate. And I just think that nurses need to know that so many of them stepped up and, were willing to, when the policies may not have supported the technology, they still stepped up. And so, but they did end up in the end, they had the support. And, when we first started seeing this on TV, we were just so rigid and, with our policies, and nurses just couldn't let this go. And so, they began to use their own phones um, it was the transition in the nursing students too that, um, just really made a difference. And so sometimes you can't follow policy. So sorry. And so now
Yes,
policy has to catch up.
okay. There is one more message from Dr. Cynthia Panster. She has already shared you her
Yeah.
feelings, emotions about her. Okay.
Well,
Any more questions?
I just wanted to share too that website from the American Nurse Association. A lot of those tools, it's, you might want to do it with a sister or, child, so that you can, make a difference. You just don't know. And we've been so busy this year. I was really impressed with what the Nursing Association had put together for us. So, but thank you. I appreciate y'all.
Thank you very much for sharing your presentation. It is very great. Thank you very much. And I'd like to open any more questions. If not, okay, if no questions, then I'll move forward to the next presentation. Thank you very much, Dr. Luana Billingsley, for the presentation. Next, we are moving to the next presentation from Nancy Lenaghan from Bayada VNA Health Group, USA. Dr. Nancy will be speaking on transitional care and empowerment of the older adult.
Hey, thank you. Can you hear me?
Yes, I do. You can now proceed.
Okay. Just want to try to get the slideshow up. Hold on. Okay. All right. So good afternoon. My name is Nancy Lenaghan, and I'm a nurse practitioner with Visiting Physician Services, which is a house call medical practice in New Jersey, about 50 miles south of New York City. I'm delighted to share my research on patient empowerment during transitions of care. In my daily practice, I'm very aware that transitions of care are weak links in the healthcare system, especially for geriatric patients who comprise a high percentage of hospital discharges. Several transition models have attempted to bridge this gap through improved collaboration and patient education. However, many healthcare organizations have not fully addressed the seamless transition of care across multiple settings. Several factors contribute to patients' challenges as they travel across varied settings of care and among multiple providers. The rise in the hospitalist movement in the United States has disrupted the continuity of the traditional primary care model, and poorly integrated information systems further hinder inter-provider communication and diagnostic follow-up. The dramatic rise in home care increases the vulnerability and powerlessness of older adults after an acute illness. Care management at home becomes the responsibility of patients and caregivers, who are often the only common denominators in a complicated healthcare system. Elder patients with comorbidities and polypharmacy often lack the assertiveness to clarify information, since they are overwhelmed by fatigue, anxiety, and sensory overload. Emotional stress, limited finances, and inadequate social support may increase elders' feelings of isolation and bewilderment after home discharge. So the significance of fragmented transition care contributes to several adverse outcomes. Disjointed transitions impede quality care and undermine patient satisfaction, and consequently, they lead to further decline in health outcomes. Medication errors commonly occur at transition points due to delayed or uncoordinated contact with a primary provider. Many of these adverse drug events could be prevented by improved surveillance and by patient engagement during cross-site transfers. In addition, ineffective transition care contributes to hospital readmissions, which have a significant economic drain on the healthcare system, as well as a negative impact on individual patients. So the existing literature on transition care highlights the merits of patients' ability to self-advocate and to actively engage in their care. I reviewed the literature extensively before I started this project, and I found that patient empowerment is a critical variable in positive post-discharge outcomes for chronically ill elders. There was also a lot of information on the health belief model, which proposes that patients will adopt a behavior when they believe that that behavior will enhance their health. So coaching a behavior to recognize the benefits, or coaching a patient to recognize the benefits of self-advocacy is consistent with the health belief model. A key research theme is provider consistency in a caring, coaching relationship focused on an understanding of each patient's unique needs and goals. Prior research has also shown that a continuous transition care relationship empowers patients while fostering confidence in themselves and in the healthcare system. However, I did find that there is a scarcity of research on the concept of patient empowerment as it relates specifically to home discharge after an acute illness. And this was the specific focus of my study. So the research focus for my particular study was, it was called Request to Safe Care at Home. And in a group of patients age 65 or older, I was asking if a patient-centered program would increase patients' level of empowerment for self-care 1 month after discharge compared to the pre-intervention level. So the Quest to Safe Care at Home project evaluated the outcomes of an advanced practice nurse-led, individualized transition intervention to enhance geriatric patients' empowerment for self-care after discharge from a subacute facility to home. So I had several hypotheses I wanted to investigate, but the central hypothesis was the first one, that patient empowerment for self-care would improve following an advanced practice-led transition intervention focused on active patient engagement. So that was my main focus of the study, was to see if there would be an improvement in patients' level of empowerment. But I also wanted to know about some of the other factors involved. Specifically, would patients with comorbidities and polypharmacy demonstrate a post-intervention confidence level equal to the less complex group? I see so many very sick patients discharged home, where in prior years that they would have been kept in the hospital for another week. So I wanted to know if those patients would be able to develop a post-intervention confidence level at least equal to the less sick group. And then I also wanted to know if there would be a positive correlation between patients' confidence to perform self-care behaviors and their belief that these actions would enhance their health outcomes. Because I really believe in the health belief model, and I wanted to find out if there was in fact a correlation between those two factors. So those were the three hypotheses that I was hoping to investigate. So this project was approved by the Institutional Review Board of both Wilkes University, where I was a doctoral student, and also Hackensack Meridian Health, which is the organization where I conducted the study. So the sample population, so using specific inclusion and exclusion criteria, I recruited a sample of older adults from a subacute nursing facility. I utilized an informational flyer, a verbal explanation, and a detailed letter to introduce the project to eligible participants. Patients were included if they were 65 years of age or older, were fluent in English, had at least one chronic illness, and were planning a home discharge. Exclusion criteria included a diagnosis of dementia, hospice care, and a subacute admission lasting less than 24 hours. There were 40 patients who met the inclusion criteria who were initially approached. Of this group, 4 were unwilling to accept home visits, 1 was admitted to ICU, 3 were transferred to long-term care, and 2 developed a change in cognitive status. So that left 30 whom I recruited. 5 did not complete the study, so that left an actual sample size of 25 patients. The demographic characteristics are listed on the right-hand side of the slide. I did not adjust for these variables in the study. It would certainly be interesting to do so in future studies. But as you can see, many of the patients lived alone. 48% had weak family support, and the level of education is shown on the slide. All right, so I chose the acronym QUEST as the focal point of my project, since I wanted patients to view their return to health as a quest or a journey. The QUEST acronym also outlined the desired patient behaviors, which were identified also in the survey instrument that I used. So I wanted patients to learn to ask their provider questions, understand their health history and current problem, become educated about their meds and treatments, know symptoms to report, and ensure timely post-hospital follow-up. So patients were able to remember the 5 behaviors that I wanted them to learn because they knew the acronym QUEST. And then they also knew that this was a journey that they were engaging on along with me as their transition coach. So the actual transition intervention in a continuous relationship with the same advanced practice nurse, that was myself, patients were actively engaged in the program, starting in the subacute facility and then continuing in their home with an intensive focus on education and teach back. I visited patients twice during the subacute admission, once in the first 48 hours of admission, and the second within 24 hours before discharge. During these 2 60-minute visits, I encourage patients to take responsibility for their health by helping them enter information into a personalized health journal. And I'll talk more about that in a minute. After discharge from the subacute facility, I visited patients at home on 2 occasions. The first within 48 hours of discharge, and the second after they saw their primary provider. During these 2 60-minute visits, I assisted them again to update their health journal with specific information about their treatment plan. I also encourage patients to role play self-advocacy skills, such as asking questions or clarifying unclear information. I found this was one of the most challenging parts of the intervention was to coach patients to learn to ask if they didn't understand something and role play self-advocacy. I also spoke with patients by phone at 7 days and 21 days after discharge, just to address their ongoing concerns and to continue to reinforce their confidence in self-care. So I mentioned the personalized health journal, and I'd just like to talk some more about that. Maximizing patient engagement during transitions requires providers to understand patients' unique goals that are most relevant to them as an individual. So this project utilized an interactive personal health journal in which patients wrote down their unique personal characteristics, such as memories, sources of pride, enjoyable activities, specific life and health goals. And this activity was intended to encourage their commitment to health by emphasizing the most important aspects of their life. I mean, patients wrote things about like they wanted to go to a grandchild's wedding, or they wanted to attend a family reunion or high school reunion, or just get back to walking on the boardwalk. For every patient, it was different, but I found that having a goal, a unique personalized goal, helped them to stay engaged. Personalized health journal was also a place for patients to record their medical history, questions for health providers, a record of appointments, plans to manage symptoms, and information about diagnostic tests, meds, and treatment plans. So it was kind of comprehensive place for them to enter all of their important information. So this study, it was a quantitative study and used a one group pre-test, post-test design to measure patients' confidence and belief regarding the 5 self-advocacy behaviors. These behaviors were derived from the Senior Empowerment and Advocacy in Patient Safety Survey, and we call that the SEEP survey for short. This was a very valid tool that addressed both content and construct validity. I received permission from the person who authored the tool, and I was able to use it. It fit perfectly into my study, and it had pre-existing validity. The pre and post survey scores were compared to determine if the intervention engendered any change in patients' level of empowerment. So the self-advocacy behaviors that were measured came right from the SEEP survey tool, and they included learning about your health problems, calling your provider to get test results, asking your provider questions, giving your provider a complete health history, and asking family or friends to accompany you to health visits. All of those items came from the actual SEEP survey, and they did correlate with my acronym QUEST, as I previously described. So patient empowerment was defined and measured by two concepts in the SEEP survey. There were actually two subscales within the survey. One was called the self-efficacy subscale, and that measured patients' confidence to perform the 5 self-advocacy behaviors. And the outcomes subscale measured the patient's belief that these behaviors would improve their health outcomes. So for each of the 5 self-advocacy behaviors, patients scored their pre and post confidence and belief on a 4-point Likert scale. 1 was the weakest and 4 was the strongest. So before the intervention, patients completed the 10-question survey to get patient baseline data about their level of empowerment. And then 30 days after the intervention was finished, or 30 days after discharge, they answered the same 10 questions so that I could see a before and after to see if there had been any change. In addition to collecting all the initial data, I also collected data regarding the number of participants with multiple comorbidities and polypharmacy. These are 2 common risk factors for adverse post-discharge outcomes. So as you can see from the slide, 48% had multiple comorbidities, defined as 2 or more chronic illnesses, and 64% had polypharmacy, defined as 5 or more daily medications. So almost half or more than half of the patients had complicated health picture. So once all the data was collected, I did a pretty extensive analysis. So the mean of the Likert scores was calculated for each of the 5 questions in each subscale of the SEEP survey. So I added up all the scores for each of the 5 behaviors and then averaged them to get a mean. And then the matched pairs of these pre and post mean scores were compared to see if there was any change in patients' level of confidence and belief in self-advocacy skills. In addition, I used Wilcoxon test to calculate the scores for each of the 5 individual survey items. I also used mixed model ANOVAs to study the effect of multiple comorbidities and polypharmacy on the post-survey mean scores for both subscales. And then I used a Spearman correlation to see if there was any correlation between patients' belief in the benefit of self-advocacy and their confidence to perform these behaviors. So I had a statistician help me. Even though the sample size was small, this data analysis turned out to be more complicated than I had expected. So I had a statistician assist me with using some of these statistical tools so I could really get a good sense of the parameters in the data analysis. So after the data was analyzed, I was happy to discover that all 3 hypotheses were supported by the data results for the sample of patients that I worked with. Patient empowerment for self-care did in fact improve following an APN-led transition intervention focused on active patient engagement. I also was happy to see that patients with comorbidities and polypharmacy demonstrated a greater post-intervention confidence level compared to the less complex group. And there was a positive correlation between patients' confidence to perform self-care actions and their belief that these would enhance their outcomes. So I'm going to just go through the specifics data for each hypothesis. So for hypothesis 1, despite a small sample size, this project generated outcomes that support the value of individualized seamless transition in improving geriatric patients' empowerment. So you can see the figure on the left shows that the mean score on the confidence subscale was significantly higher in the post-survey compared to pre-test. So it was 16.32 compared to 15.32. And then the figure on the right shows that the mean score on the outcomes efficacy or belief scale was also significantly higher. So it was 15.68 compared to 14.76. And the level of significance for both of these scores was less than 0.05. So it was a statistically significant change, even though the sample size was small. There was some significance to the change. So that reflects the data analysis for hypothesis 1. And then I looked at each individual item in the tool as well. And in addition to analyzing the increase in mean scores, I also looked at each individual item. So you can see from this chart that 4 of the 5 individual items in the self-efficacy or confidence scale, that's the middle column, increased after the intervention, but only 3 out of 4 were found to be statistically significant. So patients learning about their health problems, following up on test results, and giving a health history. All 3 of those behaviors did improve following the intervention, and they improved at a statistically significant level. In the outcomes or belief subscale, that's the column to the right, the same 4 items increased, but scores were statistically significant for only 2, following up on test results and asking provider questions. So it was a kind of a mixed response for each individual score, even though the mean average did improve significantly. All right, and here's the slide that shows the data for hypothesis 2, the effect of risk factors on outcomes. As shown in the graphs here, patients with comorbidities and polypharmacy demonstrated a post-intervention confidence level greater than the less complex group. There was a significantly higher level of improvement in patients with multiple comorbidities and polypharmacy compared to those without these risk factors. Patients with multiple comorbidities and polypharmacy exhibited lower confidence initially, and this is likely to due to their feeling overwhelmed by the tremendous burden of complex illness. But I found it quite remarkable that the more complicated patients' post-intervention score increased more than the less complex group. This suggests that while chronically ill patients face greater initial challenges to self-advocacy, they can acquire empowering behaviors following an individualized intervention. Accordingly, we as providers should set the expectation that older adults with complicated health problems have the inherent potential to manage their health and to engage in the assertiveness skills needed for self-care. All right, this final graph shows the data for hypothesis 3. And basically this shows that Spearman correlation analysis reflected that 4 out of 5 confidence items positively correlated with the belief at both pre and post intervention time points. So this suggests that there's a positive relationship between patients' confidence to perform self-advocacy behaviors and their belief that these skills will improve their health. So this is significant because when patients believe in their critical role as a health team member, they're more likely to adopt these vital self-care attributes. Hence, patients anticipating a transition to home will benefit from education about just how valuable their self-advocacy behaviors are on safe post-discharge outcomes. So this study had some limitations. Due to the project's small sample size, the statistical significance was not as robust as it would have been in a larger study. While this study shows promising results, it should be or needs to be replicated on a larger sample with adequate power. Since the study participants were culturally homogeneous, the findings may not be generalizable to other populations with different demographic characteristics. And then the study setting for this project was a subacute facility, so the results may not be transferable to older adults being discharged from hospital to home. The validity of this study may also have been limited by a ceiling effect, since higher initial confidence scores in healthier subjects may have allowed less room for improvement. So that may affect the information regarding the sicker patients improving to a greater degree. That would have to be studied further. Additionally, this research did not adjust for confounding variables such as health literacy, educational level, degree of community support, and the nature of family involvement. So this study laid the groundwork for further research to explore the relationship of empowerment to health complexity and to test strategies to engage the more complicated patients. Clinical practice would be enriched by research that explores the relationship between patients' belief in the outcomes of self-advocacy and their ability to engage in these behaviors. As researchers, we also need to identify strategies to enhance older patients' confidence in specific self-advocacy skills. While this project was an in-person intervention, it will be important to test these strategies using remote telehealth technology. So we've seen a lot more telehealth since the days of COVID. So we definitely want to see how we can use these strategies in the telehealth modality. Finally, it'll be beneficial to explore qualitative data to further enlighten ways to improve transition care. I just have to plug in my batteries. Okay, so this study has several implications for practice. So this study used one advanced practice nurse who followed patients across the care continuum. But in the United States, there is currently no reimbursement for such a model. So as healthcare leaders, we need to analyze the evidence on transition care and advocate for legislation that allows reimbursement for seamless care models. And that can be either in person or it can be via telehealth. But I think the important factor is continuity, that the patients knew the advanced practice nurse from the subacute setting. The advanced practice nurse knew the patient's entire trajectory of illness and all of the unique characteristics. And I really believe that this made quite a difference, and the previous research also supported that. So I think we need to advocate for reimbursement for more seamless care. As providers, we are accountable to bridge the disjointed interprofessional communication that hinders patients' sense of control after discharge. This is an especially serious problem for patients in subacute facilities where care is managed by an in-house clinician who may not communicate with a community-based provider. So consequently, it's essential to develop integrated electronic health records to eliminate dangerous lapses in care and to expedite the exchange of information across among providers across settings. So since a growing number of computer literate seniors are expecting web-based access to their healthcare information, nursing leaders need to leverage information technology systems to design tools to improve patient outcomes. Many of our patients now have grown up in the age of technology as they are aging, and they find that they would be empowered by electronic access to key elements of the personalized health journal used in the study. So I used a paper and pencil version, but there's no reason why we couldn't provide access electronically to those who are able to use that type of tool. I think it's also important to know that interdisciplinary collaboration is critical to support patients' empowerment and self-advocacy across the care continuum. When I worked with the staff during this project, the interdisciplinary team members utilized team meeting time to discuss patients' level of empowerment and their capacity for self-advocacy. And they told me that they had never done that before. They would discuss medications and treatments and maybe family situation, but they wouldn't look at the patient's capacity to be able to self-advocate and the patient's level of empowerment. So I think there's a need for ongoing staff education on the importance of empowerment as we plan for patients' discharge. In all facilities, and I focus particularly on subacute, but I think in all settings, patients need education on the impact of self-advocacy on health outcomes. This can be conducted during a portion of the designated social activity time in a subacute facility, and then the information could be further reinforced at the bedside. This is especially important for complex patients since they are less likely to have baseline confidence in their self-care ability. So in conclusion, despite its limitations, this project validates the benefit of continuous individualized transition care on patient empowerment, and it provides a springboard to investigate the variables that affect patients' capacity for self-care after an acute illness. Geriatric patients need to acquire sustainable self-advocacy skills to support them as they transition across multiple locations. This is especially true for the more complex patients who can benefit most from intensive interventions. Healthcare providers need to emphasize patients' belief in their vital role on the healthcare team and in the value of self-advocacy. So thank you very much for your attention, and I would be happy to answer any questions that you may have.